Now, today I'm going to be talking about something very interesting, dietary management of PCOS. Now, I still remember 20 years back when we were in Nair Hospital and we did do a gynac OPD with the gynecologist. We rarely saw, or we saw very few women coming with PCOS. I'm sure today, if there are students here or interns here who have interned in hospital, whether private or government or municipal, I think a huge chunk of population, which is female, will come with this problem. And therefore, it is very important to understand what is it that we are looking at when we are talking about PCOS. So before we start talking about what is PCOS, it is very important to understand what a normal menstrual cycle looks like. Okay, so just giving you a little bit of introduction. I know it can be boring, but till you don't understand what is normal, it is very difficult to understand what is abnormal. Okay, so normal menstrual cycle, friends, is divided into three phases. There is a follicular phase, there is an ovulation phase, and there is a luteal phase. And what is a menstrual cycle? Menstrual cycle is monthly cycling of follicle and egg maturation, release of an egg, that is ovulation, and preparation of uterine lining for pregnancy. So main thing is there is a follicle formed, there is an egg matured. Once the egg is released, that's called as ovulation, and then there is preparation of uterine lining for pregnancy. So let's look at each phase, because till we do not understand each phase, it's very difficult to understand what PCOS is. So the phase 1 starts on the first day of the period and it usually lasts up to 14 days. So remember, most of the hormonal tests that you do are done in the follicular phase. So follicular phase is the day period starts. FSH and LH are two hormones that are released from the pituitary gland at this phase and to stimulate ovaries. So FSH comes as follicle stimulating hormone. So it will stimulate to form follicle, and LH is luteinizing hormone. Both of them are released from the pituitary during the follicular phase, and that is why the name follicular. Ovaries are produce estrogen and stimulate maturation of 15 to 20 eggs inside a small cystic area, which is called as follicle. Increased estrogen causes FSH secretion to reduce so that follicle stimulation stop, because it's a feedback mechanism. There is some request here. Amrita is requesting to share the content. Should I approve it or decline it?
No, decline it.
Decline. Okay. Sure. 1 or 2 eggs in the follicle become dominant and they continue secretion of estrogen. So again, to recapitulate, first 14 days of the cycle, first day being the day you get period, to 14th day is called the follicular phase. Follicular phase, there are two hormones released from pituitary, FSH and LH. Ovaries are going to produce estrogen, which will stimulate maturation of eggs inside a follicle, and the increased estrogen will decrease the FSH later on, okay, and therefore stimulation will stop, and 1 or 2 eggs in the follicle will become dominant and will continue secreting estrogen. Phase 2 is called the ovulation. Ovulation occurs at the midpoint of the menstrual cycle. So if you look at it as a 28-day cycle, first 14 days are follicular phase, 14th day is the ovulation phase. So ovulation occurs at the midpoint of a cycle. Estrogen production from the dominant follicle leads to a sharp rise in LH, causing dominant follicle to release an egg. This egg is then swept by fallopian tube into thin structures known as fimbriae. At this time, cervix produces increased amount of thin mucus to assist sperm to pass into the uterus. So this is the ovulatory phase, and this is the phase when a lot of PMS starts happening. Then the third phase is called as the luteal phase. Luteal phase of the menstrual cycle begins the day ovulation happens. So once the egg is released, you go from ovulatory phase into luteal phase. After the egg is released, empty follicle turns into a cystic mass, which is called as corpus luteum. The corpus luteum then produces progesterone, a hormone that readies the internal lining of the uterus for implantation of fertilized egg. If the egg has been fertilized, the egg travels down through one of the fallopian tubes into the uterus and gets implanted in the inner lining of the uterus. If fertilization of egg does not occur, the inner lining of the uterus eventually breaks down and is shed, and this is what is called as menstrual bleeding or cycle. So this is the luteal phase. So remember, follicular phase is estrogen rich and luteal phase is progesterone rich, and this is a normal cycle of a woman. So remember, this is very beautifully shown, and this I am showing you because it will make the whole picture very, very clear how the hormones are rising and dropping. So this is the day when period starts. So if you'll see here, menstrual flow, okay? This is the day when follicle starts growing. This is the mid phase where there is ovulation occurring, and then there is the luteal phase. Now in the first 14 days, that is the follicular phase, if you look, there are two hormones. There is FSH and LH, both released from pituitary. If you look at it here, FSH is greater than LH. So look at LH, it is low below, FSH is high. When there is ovulation, the LH all of a sudden increases, and then both of them decline and again come up when you go back to the follicular phase. This is between FSH and LH. Now, what happens to estrogen and progesterone? In the first phase, in the follicular phase, look at it, the estrogen is increasing. It peaks just before ovulation. Once ovulation occurs, it drops, and then the progesterone picks up. And then on the 28th day, that is the day when there is period, both estrogen and progesterone are down below. Okay, so I hope this is something that you have understood. This can also be called as the proliferative phase and the secretory phase in the uterus. This is a follicular phase and luteal phase in the ovary. So ovary goes through follicular phase, ovulation and luteal phase. What uterus goes through is proliferative phase and secretory phase. Now what happens in PCOS? Now remember, this is what happens with PCOS. So with PCOS, LH levels are often high when menstrual cycle starts. The level of LH is also higher than FSH. So if you again go back here, what is higher? FSH is higher than LH. But in PCOS, what happens? LH and FSH are at the same level. Okay? Because LH levels are actually high to begin with, there is no surge of LH. So if you look here, there was a surge of LH which caused ovulation. Because it was already high, there was no surge. And because there was no surge, ovulation does not occur. And because it does not occur, periods become irregular. That is what happens in PCOS. So this is a regular menstrual cycle where there is LH is lesser, FSH is more, and then there is a LH surge. In PCOS, what happens? LH is more than FSH, and hence there is no surge at all. So this ovulation, see, this egg is being released. It is happening when LH is surging. When there is no LH surge, there is egg release is not there. And when there is no ovulation, there is no question of having a period or having a menstrual cycle. So what are the symptoms of PCOS? There are three main things, the symptoms of PCOS. There is hyperandrogenism, there is menstrual irregularity, and there is polycystic ovary. And remember, any 2 out of 3 is a diagnostic criteria for PCOS. So you don't have to have only polycystic ovaries which are visualized on ultrasound. It's not necessary. So if it is a young girl, okay, remember, young girls up till 17, 18 years of age will have, lot of them will have cyst in their ovary. That does not diagnose them as PCOS. If they are also hyperandrogenic and also they have menstrual irregularity, then maybe they are. So remember, the criteria is all these three have to be fulfilled. Out of three, two have to be fulfilled, and not just polycystic ovaries visualized on ultrasound. Now, testosterone is produced normally both in ovaries and in adrenal glands. Other androgens, other than androgens, adrenal gland also produces other hormones which include cortisol, adrenaline, and aldosterone. Ovaries and adrenal gland equally contribute to testosterone production. Women with PCOS, ovaries is a key source of excessive testosterone production in the theca cells within the ovary that is responsible for overproduction of these hormones. So what happens in hyperandrogenism? Hyperandrogenism, testosterone is excessively produced by the ovaries, and therefore women with PCOS will have masculinizing features like acne, like facial and body hair, or male pattern baldness. So if you look at it, lot of women will have regular periods, but they will have a lot of acne and hirsutism. That is lot of hair, especially on the face and also on the body, and they tend to lose hair from the crown of their head, which is called as male pattern baldness. Now, there is one hormone which you should be knowing, because these are tests which our clients do and come to you. It is called as SHBG. So it is sex hormone binding globulin. Remember one thing, hormones do not circulate freely in the blood. They travel around the bloodstream bound up with other protein that accompany them to proper destination. These proteins are called as chaperone proteins. Okay. SHBG is a protein which is designated to work with testosterone. Testosterone in high levels start to exert its masculinizing effects on neighboring organs, because it is not getting into a proper destination because SHBG is low. So therefore, it will go and bind to the skin. So therefore, there will be acne, excessive facial hair, and male pattern baldness. Total amount of estrogen may not be same. Total amount of estrogen might be same in women with PCOS and without PCOS, but the lack of carrier protein, that is SHBG, allows the excessive effect of this androgen on the person. So hyperandrogenic ovary, along with low sex hormone binding globulin, will have excessive masculinizing features like acne, facial or body hair, and male pattern baldness. Then there is a very big problem in these girls or women, that is hyperinsulinemia. Women with PCOS have a low level of carrier protein, which is called as SHBG, like I discussed here. Insulin is a major regulator of SHBG production in the liver. Higher the insulin level, lower is the production of SHBG. Human studies have confirmed that indeed high insulin levels increase androgen levels. Ovary itself is particularly rich in insulin receptors, because insulin is a nutrient sensor which informs the ovary about availability of nutrients. So high insulin level, lower SHBG, higher masculinizing features. So therefore, these are the problems that women will have with PCOS. Now we go to what can be done in PCOS. So what is lifestyle modification with PCOS? So lifestyle modification involves long-term habits, typically of eating or physical activity, and maintaining new behavior over months or for years. Lifestyle modification can be used to treat a range of diseases which include obesity and of course PCOS. So remember one thing, there is no diet for PCOS. Why? Because here the definition itself says that you have to maintain a kind of eating behavior and physical activity behavior for months and years, and not for 1 month or 2 months or 3 months that your client is with on your program. So all these are long-term things, and that is something you want to talk to your client when they approach you. So lifestyle modification is a multifaceted approach of diet, exercise, and behavior therapy. And believe me, in women with PCOS, behavior therapy sort of takes a center stage. I understand that none of us are qualified psychologists, or if there are few who have done the qualification, there may be. But remember, the problem with PCOS is there is an immense psychological burden. So I have not alluded to, but there are different types of PCOS. And in women who have a lot of acne or facial hair, they have very low self-esteem issues, and that becomes a problem. Women who probably do not have facial features of PCOS may have problem with maintaining their weight, and women who don't have the either problem are juggling with infertility. So remember that there is a huge psychological burden of PCOS on women, and therefore whenever there is high burden of or any stressor in woman's life, cortisol secretion is high. And when there is high cortisol secretion, weight gain and and relieving themselves from symptoms of PCOS will become more and more difficult. And therefore, my sincere request to everybody who is attending here is, when you have a girl or a woman with PCOS coming to you, just don't talk about diet. Talk about her, because that's very important. Unless she gets confidence in herself, unless you positively stroke her, these things are not going to work. Whether you or she's juggling infertility or she's a young girl who is just juggling to look good, it doesn't matter. We say beauty is skin deep, but truly people really go by what they see on the face, and it becomes important, especially when you're a college student or you're going to a job for an interview. These facial appearance or physical appearance becomes very, very important. So a little bit of data to show what is there. So fertility fitness program. Okay, so this is a long-term lifestyle modification result. So there was a fertility fitness program which involved dietetic and psychological counseling of women, and a multidisciplinary approach using an obstetrician, gynecologist, psychiatrist, dietitian, fitness professional, and a nurse. Okay, they documented that there was restoration of ovulation among 60 of 67 anovulatory women, improvement in pregnancy in 52 out of 67 women, and reduction in the risk of miscarriage rates at 75% pre-prevention to 18% post-intervention. But remember, it is not that only a dietitian can do it. It is not only that an obstetrician can do it. It is not only that a fitness professional is going to do it or a psychiatrist can do it. So it requires a multidisciplinary approach, because you will realize it's not only a physical problem, it has many, many other facets to it. Now, nutritional intervention, and I'm going to dwell a lot of time on it. Please post your questions if you have any in the chat box, and I'll be happy to answer them at the end. And okay, so changes in eating and in menstrual cycle. Menstrual cycle alters women's energy and nutrient intake and energy expenditure. And I think the audience today is mainly of women. You will understand that around ovulation, there is an urge to eat high calorie food. So typically, even women who do not have PCOS, okay, they will tell you that around 14th day of their period, they feel like eating energy dense foods, like maybe a chocolate or a mithai, or just a slice of pizza, anything which is high calorie food. Okay, that is because your body post ovulation is getting itself ready for implantation of a zygote. Changes in feeding behavior during menstrual cycle have been well documented. Increased fat and total energy intake during luteal phase, which is the luteal phase second half after the ovulation. So 14 day to the day that one is going to get period. This may relate to increased energy requirement, and loss of this cyclical change in energy utilization may contribute to increased weight that commonly occurs following menopause. So what happens in normal women is, normal women go through a phase of hyperphagia or preference for high energy or high fat food in the luteal phase, and then this urge goes away when you go back into follicular phase after periods. Why women gain weight in menopause or when they have PCOS, because this urge doesn't stop, because even if there is a phase like a luteal phase, this keeps on extending. So eating behavior does not change in this women. Okay, so effect of insulin on other hormones in PCOS. So remember, hyperinsulinemia increases androgen production in response to LH, and ovary also increases free androgen because of decreased SHBG. Leptin is a hormone that is produced by adipocytes and is responsible for decreased feeding. It is also involved in regulation of reproductive function, and weight loss may help to normalize this reproductive function. There is an increased ghrelin level in women with PCOS, may be a part of abnormal state of energy balance, and this abnormality is again restored towards normal with caloric restriction and weight loss. So remember, if you talk to women with PCOS, they will tell you that they never feel full. They always feel hungry. You give them a big meal to eat, within an hour, they are wanting more food. And why is it? It is because of hyperinsulinemia. I don't know what happened to my cursor. It's because of hyperinsulinemia. So that because insulin drives you to eat more and more food, because it's an anabolic hormone, and there is increased ghrelin level, and increased ghrelin level also increases hunger. And that is why, unless you give a caloric restriction, and first couple of months with caloric restriction are very difficult, but once they tide over that, you will see that ghrelin levels drop, insulin levels drop, and when both of them drop, there is normalization of other things. Okay. Weight in PCOS. There is an impression, but it is not clear from published evidence, that women with PCOS find it harder to lose weight than other average women. Improved abdominal obesity and insulin sensitivity may occur without overall change in body weight. And I'm sure in this August audience, there must be many women, people from the audience who are treating or are looking after women with PCOS. Lot of time you find that they change their body measurements, but there is no loss in weight. But their insulin sensitivity improves and their period starts cycling. Body composition of patients who exercise regularly may change with increased lean body mass and decreased fat mass, but no overall change in weight. Increased lean mass increases the resting energy expenditure and may improve hormonal and metabolic parameters in women with PCOS. Benefit of modest weight loss have become more widely appreciated, aiming for as near normal body weight and composition as possible and as feasible. This is very important with dealing with lean PCOS. Now, there is a whole segment, about 30% of women with PCOS are lean. They're actually not obese. But if you do their body composition, you will realize that their body fat percentage is still higher. It's still not in normal range. So a lot of times the question asked is, if the girl is already lean, but she has PCOS, and if she comes to us, okay, should we still look out for weight loss? You will still look out for fat loss, maybe not weight loss. So maybe try to give her exercises like weight training, increase the diet composition, change the diet composition such that there is an increased lean muscle mass so that her BMR increases, and drop in fat mass. So if she loses couple of centimeters from her waist, you will start seeing there is an immense impact on her menstrual regularity. Appetite in PCOS. Regulation of appetite is complex, and fluctuation in blood glucose may be a part of in stimulating appetite and increasing energy intake. Both insulin and glucose fluctuate very widely in patients with insulin resistance. This fluctuation commonly gives rise to something called as reactive hypoglycemia. So if again you're looking after women who actually are PCOS, they will tell you खाने के बाद चक्कर आता है, कुछ मीठा खाएंगे तो अच्छा लगता है. So this fluctuation of blood glucose gives rise to something called as reactive hypoglycemia. What is reactive hypoglycemia? Feeling low blood glucose, or sometimes even actually if you do it with a glucometer, you will see blood sugars are lower after they have eaten food, and that is because of hyperinsulinemia. Many women with PCOS describe carbohydrate craving and cite this reason for difficulty in losing weight. Madam, मेरे को मीठा खाना ही पड़ता है और because I eat मीठा, मेरा वजन कम नहीं होता. This is something. Yeah, if you try to curtail their intake of rice and chapati, they will tell you, madam, थोड़े चावल तो चाहिए वरना पेट ही नहीं भरता. Hypoglycemia is known to stimulate feeding behavior and it increases both the total food intake and total fat intake. Fluctuation in blood glucose may thus arise from changes that occur in PCOS, but may also contribute to altered feeding behavior, body composition, and insulin responses. Now, calories in PCOS. So, a beneficial effect of even modest, that is 5% weight loss on well-being, insulin sensitivity, and improvement in cardiovascular risk profile. So, this is something I wanted to discuss with you before I go ahead. So, a lot of times you will have these young girls where when their mothers get to them to you, they tell, okay, you know, I'm very worried that she has weight issues and she has PCOS and I'm really not sure if she's going to ever have children. And the young girl will typically tell in front of her mother that, but I don't want to have children ever. And therefore, that time it becomes very difficult to counsel these young girls because fertility is not a priority at that age. They are just too young to think about this. What you can talk to them about is cardiovascular risk profile. Okay, I understand that people now have become more health conscious and they are aware that at a young age, as young as 30 and 40, people, even women whom we thought were being protected by estrogen, are getting heart attacks. And therefore, you can talk to them about cardiovascular risk profile more than talking to them about fertility, because at a tender age of 18 and 19, or at an age, forget tender age, at an age when you want to prove yourself in the world and, you know, make a career, fertility is not something that a young girl is thinking about. Talk about cardiovascular risk profile, talk about missing working days, and they will start coming on your side. Modest weight loss achieved in short term may also improve hyperinsulinemia. Short periods of caloric restriction leads to decreased androgen levels, and this helps to restore the LH pulse frequency. LH remains abnormal in some patients, suggesting they may have intrinsic abnormalities of pituitary, ovarian axis function. So a lot of times when there are other problems like prolactinemia or there is hypothyroidism, even then there is a problem with the LH surge. And if there are other problems, then that has to be tackled before you start tackling things for PCOS. Sorry. Okay. Very little research is done on influence of eating pattern on metabolic parameters. Those who ate frequently in day had higher fiber and range of micronutrients. Those who ate less frequently had higher intake of fat, cholesterol, protein, and sodium. Now, this is international data. This is not true in India. Even if you ate less frequently in India, all you ate is still carbohydrates and fats only. Breakfast consumption was associated with lower energy intake and improved insulin sensitivity as compared to breakfast omission. Optimal frequency of food intake has yet to be determined, but a regular pattern with low intake of snack seems to be desirable. And snacking is something that women with PCOS cannot seem to give away. Ghrelin levels increases in response to anticipation of food. A strong argument for regular but not too frequent eating episodes in individuals who wish to lose or control their weight. Why I have put this point, and this is a research thing, this is not something I'm saying. Lot of times when clients go to dietitian, there are many meals planned. Sometimes there are 8 meals planned. And what happens is you give small meals. So maybe you are giving 5 almonds as one meal, or maybe you are giving 1 fruit as one meal. But what happens if you have written that on a diet plan and the woman is anticipating that every 2 hours she is going to eat something, even with anticipation, ghrelin levels go up. And once ghrelin levels have gone up, then maybe those 5 badams and 1 fruit that you have planned is not enough for them. So try to disperse their snacks to minimal as possible. Do not let them snack too often, because even if they are snacking healthy, there is an increase in ghrelin level, and increase in ghrelin level will somehow make them eat unhealthy later on. Okay. So what are the dietary strategies? Low fat, high carbohydrate diets, which is a mainstream approach for weight management, they appear to be no more effective than other dietary patterns. high carbohydrate dietary pattern actually worsen metabolic profile of weight loss. Modifying type of carbohydrates or glycemic index has been highly controversial. Modifying type of carbohydrate or glycemic index is proposed to improve both cardiovascular risk profile and aid in weight loss. So there is conflicting data. Education on glycemic index has not shown to have improvement in weight loss in 10-week study or in 1-year study. So there appear to be no studies on utility of glycemic index as a strategy for weight management in women with PCOS. So this is what data is saying. What is the data for replacing proteins for carbohydrate? There is an increasing amount of dietary protein at expense of carbohydrate has shown to maintain lean body mass in weight loss and reduce abdominal fat in insulin resistant subjects. These diets have been shown to be more effective in improving weight loss after 6 months to 1 year. In two small studies in PCOS, replacing protein for carbohydrate within the context of energy restricted diet provided same reproductive outcome, and postprandial glucose response was 3.5 times lower on a high protein dietary pattern. Therefore, there is data to show that proteins are better than carbohydrates. Then use of very low carbohydrate diets, the efficacy of very low carbohydrate diets for women with PCOS have not been evaluated, but a promise of considerable interest in relation to its effect on insulin sensitivity. So these are things that are recommended, and this is coming from a reproductive journal which is called as Reproductive Biomedicine. So this is not coming from a nutrition journal, and these are the guidelines which probably obstetricians and gynecologists read as far as lifestyle management is concerned. So these are just to show you what is it that they are recommending. Now, there have to be many dietary strategies. I'm going to be discussing few of them. First is meal replacement. So meal replacement has also been shown to be an effective weight loss strategy in overweight women with PCOS and may increase flexibility within energy-reduced diet, potentially to aid compliance and adhere to energy-reduced diet. So in a study, 34 overweight women with PCOS on weight loss intervention, that is 2 meal replacement, low fat snack, and an evening meal for 8 weeks. The intervention resulted in reduced weight, waist circumference, reduced testosterone level, and free androgen index. Okay, so this is the effect of on PCOS of things where you can, where insulin resistance is dropped, HOMA-IR is dropped, insulin sensitivity is increased, so on and so forth. So these are various studies. And again, I'm not going to allude to that because they are just studies which have shown what meal replacements can do. Okay, so meal replacement ultimately is shown to be effective because you will see the drop, the weight dropped, waist circumference dropped, body fat dropped, insulin dropped, total testosterone dropped, and free androgen index dropped, and they were sustained over a longer phase. Then there is something called as anti-inflammatory diets, and these are very interesting. In PCOS, glucose ingestion, okay, so ingestion of glucose or high glycemic diets induces an inflammatory response as evidenced by increase in reactive oxygen related oxidative stress, increase in NF-kappa beta activation independent of obesity. Release of tumor necrosis factor alpha and interleukin 6 from circulating mononucleosides is also altered in PCOS by glucose ingestion in vivo and glucose exposure in vitro. So these are markers of oxidative stress and inflammation are associated with glucose challenge measures of insulin sensitivity or fasting measures of insulin resistance. Diet-induced inflammation in PCOS culminates in a pro-inflammatory signal known to develop into insulin resistance and atherogenesis. So remember, as it is, obesity is a pro-inflammatory state. Okay, to add to it, if you eat pro-inflammatory diets, then this inflammation is going to go high. So what are the principles of anti-inflammatory diets? The principle of anti-inflammatory diet is diet should be low in glycemic load. So not only in index, but in load. What is the difference between index and load? Index talks about type of carbohydrate, load talks about type and amount of carbohydrate. So not only the type has to be right, but the amount has to be less. The diets have to be low in omega-6 fats. So no refined oils which come from corn, sunflower, so on and so forth. And it has to be rich in eicosapentaenoic acid. So what are carbohydrates in anti-inflammatory diet? Macronutrient composition, sorry, hello? Macronutrient composition of such diet would provide around 150 grams of carbohydrate, that is coming 600 calories per day from low glycemic load source. This can be achieved by consuming 10 servings of non-starchy vegetables, which comes to about 200 calories, limited amount of fruit. And I want to dwell on this because of their higher carbohydrate content, a relatively rigid but not a total exclusion of high glycemic load carbohydrates such as bread, pasta, rice, and potatoes. Proteins, again, about 100 grams of protein, which come from low-fat sources such as fish or chicken, or vegetarian sources such as tofu or soya imitation products. In anti-inflammatory diets, we'll have about 50 grams of fat per day, with very little fat coming from omega-6 sources and saturated fat. Okay, so they are all pro-inflammatory and hence they are not recommended. Monounsaturated fat should be supplemented at least 5 and supplemented by 5 grams per day of long chain omega-3 fatty acids. Okay, so what is the macronutrient composition of this diet is considered as 1 to 3. That means for every 1 gram of fat, we will have 2 grams of protein and 3 grams of carbohydrate. This will stabilize postprandial insulin levels, thus relieving inhibition of hormone-sensitive lipase in the fat cells. As a result of this, there is a release of stored fat for ATP production. The 1 to 3 ratio has been shown to be superior in reducing hunger, reducing insulin, stabilizing lipid levels, reducing blood glucose, increasing weight loss, characterized by high initial insulin secretion to carbohydrate and reducing silent inflammation. So these are very, very effective diets for PCOS. Now, how many calories do you give? So there is a lot of data, but they have shown around 1200 calories per day is good enough to reduce insulin resistance. So try not to give more even if women are exercising. And then there are a lot of other benefits which come from anti-inflammatory diet, mainly reduced inflammation. Hello, am I going over the time? Hello?
Continue. Continue.
No, ma'am, continue, ma'am.
I think we need to mute the audience.
Manisha Kumari, can you please mute yourself? Manisha Kumari, can you please mute yourself?
I'll do it from here.
Okay. Then there are a lot of spices in anti-inflammatory diet, and one of them which we use a lot in Indian diet is turmeric. Okay, and why is turmeric a good anti-inflammatory? Because it's anti-inflammatory in nature. It inhibits prostaglandin synthesis. It detoxifies. So these kind of spices are great for women with PCOS. So there is also anti-inflammatory index, and I think there is a lot of talk about dietary inflammatory index, and diets have shown to modulate inflammation. There are large variety of foods are available in an average diet that results in large number of nutrients that can interact with each other, producing synergistic and antagonistic effects. Lot of times in Ayurveda, they speak about nutrient composition. ये इसके साथ नहीं खाना. That is probably because of the dietary inflammatory index was proposed to have an effect on individuals' diet. And this is dietary inflammatory index scoring. So if you look at it, even energy has a high index. Carbohydrate has a high index. Fat has a high index. But if you look at all vitamins, it has a low index. So more energy you eat, more carbohydrate you eat, more fat you eat, you will have higher amount of inflammation. Same is true for trans fat. Look at trans fat. It is higher than even total energy. So it's 0.02. So look at trans fat. Look at saturated fat. But look at MUFA. Other things, but they are much better. So try to eat foods which have a negative inflammatory index. And unfortunately, I mean, on this list I know there is alcohol which also has a negative inflammatory index, but also does fiber. And among all the new macros, if you see, protein has the lowest inflammatory index among all the nutrients. So whether it's carbs, fats, others, protein is much lower, and hence high protein diets produces low amount of inflammation. Obesity and PCOS both are inflammatory conditions, and therefore try to decrease it. Okay, now how do you make changes in Indian diets to anti-inflammatory? Less emphasis on carbs, that is less emphasis on roti, rice and millets. Please emphasize very little as far as diets for PCOS goes. More emphasis on pulses and dals because they're protein rich and also fiber rich. Inclusion of lot more locally grown non-starchy vegetables like bottle gourd, rich gourd, various green leafies, beans, drumsticks, so on and so forth. Less emphasis on omega-6 fats and use of MUFA as a preferred source of cooking fat like groundnut oil, rice bran oil, mustard oil, so on and so forth. Inclusion of nuts like walnuts and almonds in diet for ALA and MUFA content. Inclusion of fish or fish oil supplements. And moderate use of less sweet locally grown fruits like jamun, guava, pear, etc. Then we know there is another dietary product which will increase inflammation, that is advanced glycation end product. And we know advanced glycation end product are heterogeneous complex group of compound that are formed when reducing sugars act in non-enzymatic way with amino acid and proteins and other macromolecules. Okay, this occurs both endogenously within your body. So HbA1c is one of the advanced glycation end product, but exogenously in food also it increases, and higher age occurs with chronic diseases, and this is how age happens. So glucose reacts with proteins, forms a Schiff base and forms the amidori product. So this is HbA1c is one such amidori product. Now when there are age, there are receptors for age on the cells. They are called as RAGE, and when age and RAGE bind together, they trigger activation of mitogen activated protein and others, which will lead to NF kappa beta kind of factors, which will lead to increased inflammation in body. So what are the effect of cooking procedures on age formation in food? So remember, there are a lot of data or lot of studies which are done on age. Again, simple example is if scrambled eggs are prepared in an open pan over medium heat, and had about 1.5 age products as in same way when eggs are prepared over high heat. So all your dadi maka cooking was low heat cooking, and that is really, really good. Poached or steamed chicken has about a fourth of age as compared to roasted or broiled chicken. So a lot of times when girls with PCOS come to us and we are advising them diet, they typically ask, bahar jaake kya khaye? So you will say tandoori chicken or you will say tandoori paneer. Remember, anything which is roasted or broiled, okay, in an oven will have more age as compared to broiled products. Can you please mute yourself, whoever has unmuted? All foods which are exposed to high temperature with lower moisture levels will have high age products, and hence do not advise too many roasted products to these women, rather advise poached products which are good. Incidentally, microwaving did not raise age content to the same extent as dry heat cooking methods for a relatively short period of times. So remember how to choose food. Okay, so it is noteworthy that lean red meats. Can you please mute yourself? It's very disturbing. Red meat, poultry contain high level of age when cooked under high heat or high dry heat. High fat aged cheese such as full fat American Parmesan will contain. Can you please mute yourself? High fat aged cheese such a, okay, so I have spoken about that, will contain more aged products as compared to reduced fat mozzarella, cheddar or cottage cheese. That's your paneer. Okay, so try to avoid products which are high in fat. More dry baked products such as crackers, chips, cookies will have more advanced glycation end product. For example, biscuits had 10 times more of age than found in rotis, rolls or bagels. So remember, more processed food, more is the age. And last one, just last few slides, seed cycling. So seed cycling is a naturopathy remedy for PCOS. Okay, it claims to balance hormone. Sushila, can you please mute yourself? Okay, so it claims to balance hormones by regulating hormone estrogen in first half of your menstrual cycle and hormone progesterone in second half of your menstrual cycle. There is a lot of anecdotal data talking about its usefulness, but there is no scientific data that backs the claim. What does it involve? It involves eating flax, pumpkin, sesame, and sunflower seeds at different times of month to balance the hormones in the woman. In the follicular phase, that is the day you get period to the 14th day, 1 tablespoon each of freshly ground flax and pumpkin seeds per day for first 13 to 14 days. In the luteal phase, 1 tablespoon each of freshly ground sunflower and sesame seeds until the first day of the period. Now, the problem you will ask me is that in women with PCOS, they do not get periods every month. Then how do you know whether they are in follicular phase or luteal phase? So what you should do is ideally give all seeds all the time because you really don't know which phase are they in. I personally don't use much of it, but I am telling you that there is a lot of anecdotal data that it will work. During follicular phase, phytoestrogen in flax seeds can help increase or decrease estrogen levels as needed. Phytoestrogens are compound in plants that can mimic estrogen level. Additionally, zinc from pumpkin seed is claimed to promote progesterone production in preparation for the next phase of the cycle. During luteal phase, lignans, that is polyphenols, in the sesame seeds are supposed to inhibit estrogen levels from increasing too much. Vitamin E in sunflower seeds is thought to help to boost progesterone levels. Okay. Now there is a case study which I am going to show of one of the women who came to me. So this is a 33-year-old woman with a 5 feet 2 inches of height and 93 kgs of weight. She was diagnosed with PCOS and referred to dietitian for a lifestyle modification. Pharmacotherapy, she had a history of taking metformin, but she herself discontinued it because of gastric reflux disease. The patient currently is not taking medications, is solely on lifestyle modification program. She's a working Maharashtrian woman. She's married for about 8 years, unable to conceive. Her dietary recall showed that she is consuming about 1700 calories per day, with 70% calories coming from carbs, 5 to 7 from protein, about 25% calories coming from fat. She's very conscious of her fat intake. So this is her dietary recall. In the morning, she has a cup of tea with sugar and 2 khari biscuits. In breakfast, she typically has 1 roti and sabji before she leaves for work. She's a working woman. For lunch, she has 2 rotis, sabzi, and a half a bowl of salad that she carries with her in a dabba. In late in the evening, she has a cup of tea and something from outside. It can be Frankie, vada pav, it can be even misal, bhaji pav, whatever. And dinner will be 2 vatis of cooked rice with chicken curry, fish curry 3 times a week, or 2 rotis, dal, sabzi on the day she is vegetarian. She comes from Konkan, so there was use of abundant amount of coconut in her cooking. Okay, so we did her lifestyle intervention program through 11 months. Okay, so we started with planning of 1500 calories per day with just 55% coming from carbs, about 15 to 20 from protein, 25 to 35% coming from fat. Coconut intake was reduced. Mufa-rich oils were incorporated like rice bran, groundnuts, soya. Nuts were included in our diet. Frequency of non-veg food, because she would enjoy it, was increased because you need something to gratify your taste buds, to 4 to 5 times a week with egg whites, lean cut chicken and fish, and meal replacement was added in the diet as a snack along with food once a day. Okay, so this was the menu that we gave her. Morning, a cup of tea without sugar, so that with sugar became without sugar. Instead of curry, we gave her nuts. We gave her some amount of exercise, gave her breakfast with 2 to 3 egg white omelette, or besan mung chila, or missi roti, or something like that. Mid-morning was a fruit. Lunch was either dal or usal, katori of salad, katori of curd, 1 roti. Evening was tea without sugar with nuts and a meal replacement. And for dinner, we gave her chicken and fish about 4 times a week. We told her to avoid coconut, adding coconut to it, or even if she added very little. So like it was, she came from Konkan, so they typically make a coconut based curry. Instead of that, we told her to put little coconut in her curry instead of making it completely coconut based. and a bowl of green leafy vegetable. There was an exercise plan given to her. She did yogas on weekend with about 20 Surya Namaskars. Other days she was doing walks. So she normalized her cycles. She did lose a lot of weight. She normalized cycle, normalization of hormone profile, improvement in blood sugar and lipid profile, especially triglycerides. And of course, there was a boost in self-confidence. I have her pictures, but just because she is my client, I don't want to show it. I don't think it is good for patient confidentiality. Thank you so much for a patient hearing.